discussed the role of cardiologists, I think, in many words before. So one point I would like to mention that one important part of maintaining these patients on after heart transplant is immunosuppression. It's just like a kidney transplant. So unless you keep them there, the longevity is going to be affected. So like, for example, here, historically also, the evolution of new drugs, the 70s and 90s and 2000s actually led to better survival now in heart transplant cases. For example, the introduction of tacrolimus and mycophenolate. So it's important to know the insights and final points of these medicines also, and it's also done by cardiologists. So there are two ingredients for a successful heart transplant program. So one is the surgical aspect, which has already been mentioned by Dr. Gokhale and the previous speaker. So exactly what are the surgical challenges, what are the surgical problems, and how you match the organ, etc. But there is also an immunobiology problem, which we actually tend to undermine, just like a kidney. So because this is all, after all, unrelated organ. So there is going to be a chance of rejection. There are various types of rejection, which I'll just mention briefly. And it's very important to basically manage them whenever they arise, and they do actually arise post-operative. So who needs heart transplant? This is actually the ISHLT criteria. Dr. Gokhale has already gone into all this. So in nutshell, end-stage heart failure, post-MI or any other etiology, EF less than 25. RV dysfunction is also important in this. Other etiologies have already been mentioned. So this is again listed in the 2016 ISHLT on criteria of 10-year update. Again, they updated again after that, after about 8 years, last year again. So I think one should refer this important document. Contraindications for heart transplant. Now, again, the same thing has been discussed. So irreversible pulmonary hypertension. So if the pulmonary PAH, in spite of all the manuals, as Dr. Gokhale mentioned, vasodilators, IABP, whatever other mechanical, if still the PVR is high, TPG is more than 16, it's a difficult case. High creatinine levels. Again, mentioned in the light of the right ventricle problem. Someone said if RV is bad. So when RV is bad, actually it's not the RV bad is the problem. The creatinine levels will lead to a cardiorenal syndrome or CKD, which actually creates a problem for the heart transplant. Again, hepatic fibrosis due to chronic RV failure can lead to early cirrhosis, which is a challenge for heart transplant. Others are malignancy and AHS, etc. So combined heart and lung. Now there is a role for combined heart and lung, which has been done in our unit, in Dr. Bala's unit here. So Eisenmenger syndrome, PPH. So we are done also in children. So again, there is indication for this. So in the post-op period, what are the problems which sometimes they ask us to manage or at least help post-op ventilation 48 hours? IV steroids sometimes needed. The dose may have to be adjusted depending on infection and other things. Drains and pacing wires, all this we have to monitor. Antibiotics, sometimes infection can be a problem. Inotrope, generally we give isoprene, very important to keep the heart rate more than 100. Other hemodynamic monitoring is important. So the post-op basic problem in heart transplant is a clinical slope, slippery slope. So we have to balance infection, rejection, and renal dysfunction. These are the problems in the first few weeks. So what do we do to avoid it? One of this is induction therapy. So induction drug is one drug which has been used especially when the GFR is low. So drugs like ATG and basiliximab been given. These drugs are given prior, just before taking the patient for transplant, to avoid tacrolimus, to avoid giving tacrolimus in the first 3-4 days, so that the kidney is spared. So the renal sparing basically indication for these induction therapies. So these are various drugs as I already mentioned. Generally we use basiliximab. And then I'll just spare it. Other drugs what we use for immunosuppression, calcineurin inhibitors. So the common ones used actually is tacrolimus we tend to use more. Cyclosporin, tacrolimus. Then azathioprine is used as an alternative drug to mycophenolate. So earlier it was used more, but now is used if mycophenolate intolerance. Patient is not tolerating mycophenolate, you use azathioprine. Otherwise you use commonly CR9, that is tacrolimus plus mycophenolate at various doses. The other option is an mTOR inhibitor, like one which is actually works on the mTOR pathway. So this again is used instead of tacrolimus. So tacrolimus is creating a kidney problem. We tend to go for everolimus, and that way try to save the kidney post-operative. And this usually happens late 6 months to 1 year or 3 years after heart transplantation. So heart transplant is an unrelated donor, hence overcoming that threat of rejection is very important. So what are the problems, factors which affect it? ABO, cytotoxicity, flow match, especially all he has mentioned, or Gokhale has mentioned. Post-heart, now what we focus on is the post-heart transplant surveillance techniques. So we do some surveillance basically to avoid or prognosticate or predict rejection. So one of the important one is endomyocardial biopsy. So generally a biopsy is done in the first 4 weeks after the heart transplant, then at first year and then every year. Many surgeons tend to do it in the first 6 months also, at the first 6 months. So 3 times in the first 1 year, then every year. This is our standard protocol in India. In US and other countries, they do even 10 times per year. So the biopsy-proven rejection, again, as this study from Shah and 13 and other studies show, has significantly come down. Somebody mentioned about 15% by the use of these new drugs like mycophenolate, azathioprine, induction, etc. So, of course, these are the various types of host versus graft rejection types in heart transplant. Hyperacute, which happens on table. There could be cell-mediated rejection, acute, cell-mediated AMR, chronic, etc., etc. So it's our job to differentiate all these and choose the right therapy if it happens or prevent it. So there is an ISHLT grading criteria on the heart transplant biopsy, so which actually is different from cell-mediated immunity or CMR and AMR. This is mainly a pathological problem, but still because we have to take the biopsy, we have to know. So the CMR is generally graded as 0R, 1, 2, 3R. And AMR is again graded in different ways, PAMR 1A, 1H, 1I, and then increasing grades. So each has a particular kind of significance. For EM biopsy is generally done in the cath lab. Generally we use femoral vein, we could use the jugular vein also, and we use the Mullin's. Generally our lab we use a Mullin sheath and then use a bioptum, a 5F adult bioptum for pediatrics, a 3F bioptum to take 2-3 myocardial pieces, about 3 mm. And put it in formalin to send to the pathologist. In our experience, this is from Dr. Bala's unit, 452 cases, about 18% at CMR, grade 2 CMR, another 55, that is about 15%. And some of them were very sick AMR, grade 2. So this about 24 cases had very severe grade of AMR who are very sick and needing further therapy, like what he had mentioned one case in which we had to use steroid, plasmapheresis, IVIG, etc. So there is a particular group of patients who become very sick with AMR, or antibody-mediated rejection. And the survival, 84% at 1 year. And these are the survival rate, basically on the Kaplan-Meier analysis, which are already published in Indian Heart Journal. Same thing. Now, one of the downside of EM biopsies, if you do it frequently especially, then is invasive test is painful. There is some risk. In experienced hands, we have very little risk of pericardial tamponade or myocardial injury, but there can be. There are sampling errors. The predictive value is also one problem, because when you do a biopsy, still a patient can get a rejection after 2-3 months, or 3 months or 4 months. It's not that it is 100% foolproof. So because of all these problems, I'll just skip this escalating problems in advanced heart failure. Because of all these problems, there are non-biopsy markers which have been developed, which I will just come to. So the role of cath lab, again, the role of cath lab is very important. First is to actually measure the transpulmonary gradient. So TPG, as Dr. Oakley mentioned, basically is the difference between PA mean and wedge mean. And this is a very important or a common parameter what we measure actually to see whether the patient is fit or not fit for an isolated heart transplant. And this TPG is done, ideally should be less than 16, and of course measured after giving vasodilatory drugs. So we do it after giving milrinone or sildenafil, sometimes nitric oxide, sometimes patient is on IABP for 3-4 days and remeasure. So whatever is there, this is the final TPG is what we rely on. So we should make sure that the TPG is not missed, and so that on table the surgeon is finding some other TPG. The TPG here mentioned 16 and surgeon measures it as 30, and then he gets into a problem on the table. So that should not happen. So that's why the idea, that's why the TPG is very rigorously measured in the cath lab itself. So for example, the patient who has pulmonary hypertension, the patient A has a TPG of 22, it falls to 14 in vasodilator, but his RA pressure is high and stable. But he generally will take a longer CPB time and longer ICU time after surgery, and although he has pulmonary hypertension. But the person whose TPG is low, generally they sail through much better. Although at 1 year, roughly the prognosis might be same. So persons who have higher pulmonary hypertension, reversible, still have a higher post-operative challenges and problems in the post-op period. This all I'll pass through. The same thing mentioned in previous publications. And how to bridge patients for heart failure. This is one thing which I want to mention, because the timing, Dr. Gokhale has mentioned that VO2 max should be 14, patient is having recurrent heart failure. But there are some patients who anyway are going to become sick, and then your heart is not going to be available in a day or two. You are going to list the patient. That is a big problem for heart transplant, because there is no heart available in 2 days. There may not be heart available in 1 month also. So it's very important to bridge this patient. So that is why this concept of bridging has come. So now we need to keep these fellows alive till the heart becomes available or LVAD happens. So in order to do that, one of the things could be an ECMO. So we have to consider an ECMO. If your unit has somebody doing ECMO and patient is getting sicker and sicker in the intermax gradient, VA ECMO could be an option. So ventricular arterial ECMO. This can keep the patient, urine output is falling, at least end organs perfused for at least a period of 5-10 days or 1 week. After 10-15 days, patient may have low platelets and other problems, bleeding issues due to ECMO, which can be taken care of at that time. But if you can get a heart transplant on ECMO, at least you can save the patient. The other option on this is a CentriMac. Bala has mentioned that in case patient is not tolerating an ECMO, for various reasons, a VAD, temporary VAD is a solution, which is also possible in the theater. You put a cannula in the left ventricle, and then unload the ventricle. It could be an RV also. And then the patient is maintained on external LVAD, external VAD, it is CentriMac. So this also is a good way of bridging the patient. Other ways of bridging is sometimes a right heart support, using a Impeller right RP or a Protect Duo, or sometimes a VA ECMO. So these are things which one should always keep in mind before a heart transplant. This is a Protect Duo cannula which you had one use, jugular vein. So this is basically a double lumen jugular vein cannula which goes till the PA, through the jugular vein into the PA. So one orifice in the RA, another orifice in the PA, and then external pump, it drains out actually from the RA and gives support to the right ventricle, pulmonary circulation. So this is one way of actually maintaining the patient. So this patient was maintained like this on 3 or 4 weeks and had a transplant after that. Now again, come back to the non-biopsy markers. So heart transplant is difficult. Biopsy is a bit risky. In some patients, it's again risky due to arrhythmias and other problems, or you cannot afford. The problem is the cost of biopsy is also increasing. So we have certain non-biopsy markers which are now available. So one of them is basically these biopsy markers mentioned over immunosuppression versus under immunosuppression in a way. So one of the markers are donor-specific antibodies. So you have antigen bead or single antigen bead measurements in which the antibody levels can be measured post-op. This is more important for AMR or antibody-mediated rejection, and in which you can measure the level of antibodies using MFI and can have an idea whether really is going for AMR rejection. The other test available actually is the AlloMap test. The AlloMap test is a gene expression analysis. It's not available in India. So what is available in India is actually, apart from the anti-HLA antibody, AlloMap is not available, is the cell-free DNA. So we have a cell-free DNA test available. Now a double DD cell-free DNA or double-stranded cell-free DNA test is a single-point test taken from blood sample, about 5 ml, which can measure whether the patient has higher risk or has an ongoing rejection. It is actually more sensitive for antibody-mediated AMR and less for CMR. But still it will give an idea whether the patient is going for a rejection or not. If patient has a borderline LV function, cell-free DNA can be used. It is now available now in India through various labs. So cell-free DNA is one test which we commonly tend to use along with before a biopsy. So this is a method of the cell-free DNA and validated by some trials like the Cargo 2 trial. Sensitivity of this AlloMap and CFDNAs are almost same. They're quite good. And there are other genomic tests which are now coming up using AI and artificial intelligence, etc. Molecular microscopy. The other problems which cardiologists face is about infection. So there are a lot of infections which we do see in transplant practice which we have to manage. One of them is cytomegalovirus infection. It is not so common, but still it happens. And sometimes it can lead to severe diarrhea and sometimes liver dysfunction, and we then have to treat them, admit and treat. Other one is a candida infection, mucormycosis, sometimes sepsis due to any cause. COVID also we had multiple cases. Tuberculosis we have to be on the guard, other fungal infections. So these are some of the problems what a cardiologist faces. So I'll stop here and take any questions.